Well, thanks for having me. We were just talking a minute ago. It's really awesome to be here because both 1871 and Matter are just so needed in a city like Chicago, where it's hard to get people together and get startups all leveraging one another. So it's great to be here. I'm going to go super fast because I go super fast, but at the end we have time for Q&A and we can talk a little bit about what we're up to. We've spent the last, meaning Brad and I, my partners, the last 2 decades applying technology to antiquated industries. First in the printing industry, we started Interworkings in 2001 to basically apply technology to printing. And all these companies have a common theme, and that is they structure unstructured data. They make sense of antiquated data and find ways for people to gather insights from that. Then we started a company called Echo in 2005, which is in the transportation logistics space. Then we started a company called MediaBank in 2006. Then we started Groupon in 2008, and then Uptake in 2014. I think all total these companies employ maybe 15,000 people. It's probably 6,000 or 7,000 engineers across the entire platform and data scientists. So it's an army of really talented engineers and data scientists and people that are supporting them to basically answer questions in industries that historically have not had a lot of technology. The only 2 industries I thought I would never be in were banking or healthcare. But a few years ago, I was touched by cancer in a way that a lot of people are. And I began thinking this is just crazy that there's more technology in the transportation industry. Truck drivers have more technology in determining what pallet to pick up than we arm physicians with when they're making some of the most important decisions you can make. And so that began a journey of me running around trying to figure out if there was a better way to do this. Anyone who has had a loved one that's had cancer. Some of the most painful words you could ever hear are you have cancer. The process of diagnosing it and treating it has remained largely the same over the past 50 years. Something goes wrong, which triggers your doctor to basically do a biopsy. In a few days, they come back and say something like, you have a tumor, it's this big, it's in this location, and its place of origin was X or Y. And that's what you hear as a patient or as a family member of a patient. Basically, at the end of that, no matter what type of cancer you have, and there are roughly 200 subtypes, the outcome is going to be largely one of 3 things: chemotherapy, radiation, or surgery. A little bit of immunotherapy, but still in terms of the number of patients that are getting immunotherapy today is still small relative to the total patient population. And this is happening to about 1.6 million people a year. I think the latest stats actually about closer to 1.7 million. So this is happening to just in North America alone. If you live long enough, it affects nearly 1 of every 2 men and 1 of every 3 women, so you can't escape it. And it's responsible today for roughly 20% of all mortality rates in North America. About 600,000 people a year die of cancer. This stat's a little old. Today it's estimated to cost the government alone north of $100 billion. And when you add up all the money we spend on cancer, it is both the major revenue source for hospitals across the country, and it's also the major cost center. So you typically die of 1 of 3 things, not to have this be a totally morbid conversation, but you die of 1 of 3 things: heart attack, cancer, or stroke. We've made significant progress in the other 2, but in cancer, the mortality rates are still quite high, and the total number of people dying of cancer is been largely unaffected over the last 25 years. The percentages in certain cancers have been dramatically improved, but any offsets that we've made in reducing mortality rates have been offset by an aging population, and so net, you still have 600,000 people a year that die of cancer. So the question is why? I ran around and was perplexed at how little data was in the clinic. I was fortunate that at the time I was funding research at maybe a dozen of what they call the NCI cancer centers. There are 69 NCI cancer centers that basically are the top cancer centers in the country. And I ran around and met with a bunch of them. I also met with a bunch of private companies that claim to have big data solutions for cancer. And I became convinced that the entire system was broken, and that at the end of the day, you couldn't usher in an era of personalized medicine or precision medicine until you fixed the most fundamental of problems, which was the underlying data structure. Today, for anybody who works in a hospital system, and certainly works on cancer, you would realize that you have to touch multiple systems in cancer. You have to touch anatomical pathology systems, and that's a completely siloed system, but that's the slides that pathologists look at when they come back and say to you, you have X or Y. You have to touch all this scan and image data, predominantly coming out of places like radiology, where we're tracking the size of your tumor and how it's progressing over time. You need molecular data, which is the new emerging field of genomics. You need molecular data, and there it's not even a matter of how do I get a hold of that data. There it's really a function of how do I generate that data, because it's only over the last 10 years that we've even been able to generate that data at a cost structure that is economical. And so the biggest problem we have in molecular data is how little of it's being generated. The largest company in the space will sequence maybe 100,000 patients this year out of 55 million, assuming they only got sequenced once. And then you also would need to get your hands on clinical data, predominantly phenotypic, therapeutic, and outcome data that largely resides in big EMR and EHR systems, and it's also completely siloed. I joke, although it's not a joke, if I were designing a system from a data perspective, and my singular intention was to inhibit progress as much as I could, and to make it as hard as possible for patients to be treated, to make research move as slow as humanly possible, you would design almost to a T this system. You would silo data, you'd make it so nobody shares, you'd make it impossible to figure out who's going to pay for what, you'd have everyone fighting over IP, nobody would ever share anything, you'd create unbelievable regulatory burdens, you'd live in our world. And so when we talk about all this amazing technology like CRISPR or personalized vaccines or whatever it is, the very first thing you need is to fix the data problem. You don't have clean data. If we can't help physicians and researchers get a clean data set, they can't usher in personalized medicine. We launched Tempus to solve that problem. The idea was we were one of the few people in the country that had real technology scale, meaning thousands of people that we could throw at this problem if we needed to, and we had capital, and we had experience at building these kind of systems in other industries, and so we felt, if it doesn't exist, we need to build it, or I felt if it doesn't exist, I need to build it. And so we launched Tempus about a year ago. So we'll show you a quick video, and then I'll show you the software, and then we'll talk. My motivation for starting Tempus was personal. I watched a family member actually being treated inside a clinical setting, and I realized just how critical it was to bring technology to the very physicians that were seeing patients every day.
My vision is that we're going to live in a world where every patient is treated for cancer based on the data and the knowledge in aggregate of all the other patients who have come before him or her. And that's what Tempus is doing.
We now can gather incredibly rich genomic data, but how do we analyze it? How do we help physicians make decisions while they're treating a patient that might actually improve outcomes? That's what Tempus is delivering. We built a platform to help physicians in clinic while they're treating patients analyze incredible amounts of data and make real-time decisions, the kind of real-time decisions that allow patients to effectively buy time.
I've faced the challenges of trying to cut through all kinds of information. To bring genomic data into clinical care, we need to combine the molecular data with the phenotypic data, and that combination of data will allow for powerful decisions.
We've assembled an amazing team, computational biologists, bioinformaticians, sitting next to mathematicians and software engineers and data scientists, all with a common goal. How do we improve patient outcomes?
Our approach is very different than just a technology company, because at our core, we believe that you need to put great technology in the hands of physicians. We're not here to sell you a test. We're not here to sell you a service. We're here to solve a problem that says, how do you build precision oncology and have a system that can power that?
A physician's time is extremely valuable. The more time they spend pecking away into a clinical record system, the less time they spend treating their patients. What Tempus has done is build software that allows them to make the most use of their time.
Here at Northwestern, we are very excited about our partnership with Tempus. Personalized medicine has been an important goal for a while, so keeping up with technology is critical for the next wave of research, and we need a good partner in the industry for that, and that's what we found in Tempus.
We were very excited to partner with Tempus in terms of really scaling the OncoSeq test that we've developed here at the University of Michigan. There's only a limited amount that we can do at an academic medical center. We felt that we would have a much larger global impact on cancer by working with an entity like Tempus.
There's nearly 600,000 people a year that die of cancer. And if we can help reduce 10% of that or 20% of that, what an amazing accomplishment that would be.
So from the point of view of a clinician, so from the point of view of an oncologist, how does life change in a world that's powered by Tempus?
So in a world that's powered by Tempus, what ends up happening is, even though the patterns are relatively straightforward, the data becomes infinitely more valuable the more institutions come on board, right? Because as institutions come on board and we begin sequencing more patients and working with them to extract data, we're retaining a de-identified copy of that data inside our database. In a world where Tempus is ubiquitously deployed, there are hundreds of thousands of patients in our database for which we have that rich exome data. It's also clinically annotated, so we know who these people are. Are they smokers? Are they diabetic? What drugs did they take? How did their tumor respond to those drugs? Are they alive? Are they not alive? What's happening? And that database, the knowledge of every patient that came before, is visible. Those patterns are visible to every doctor on our system. So when you come in a world where Tempus or technology like Tempus is deployed, you come in and you have a problem, right? Something hurts, something's wrong. We do a biopsy. Within a couple of days, the pathologist says, this doesn't look good, right? At that moment, from those same slides that we made an anatomical call that you have cancer, we begin sequencing you, right? So within a few days, it comes back and we know exactly what your molecular composition is. We know what mutations are driving this cancer. And we've been able to look inside this giant library of patients just like you, try to figure out who's responded best to what therapy. So when you walk in to have that first meeting with your oncologist to say, here's how we're going to handle your diagnosis, it's not as gray as it is today, right? There's some data that's going to drive that decision. And that's the world we have to live in.
At some point when Tempus gets to scale, you will be able to, an oncologist will be able to say to someone, because you have this type of cancer, we're prescribing this particular type of therapy, and here's the outcome that we expect.
Exactly. There'll be waves of this. And by the way, Tempus won't be alone, but there'll be waves of this. The first wave will be, you don't have ER-positive breast cancer. First wave will be, you have PIK3CA, RB1, TP53 breast cancer. It's got basal-like tendencies. You have these expression levels of PD-L1 and CTLA4 and CD40.
You also described some of the challenges in healthcare, and that if you were designing a system, something to the effect of if you were going to design the worst possible system to integrate data to help patients, you'd design the healthcare system we have today.
Yeah.
So the cost of sequencing has plummeted, as you pointed out. So the cost of collecting this data, of storing it, the analytics have gotten much more sophisticated. How much are you running into walls because of the way that the healthcare system is structured today, and what are some of those barriers, and how are you dealing with them?
One of the great challenges, I think, is even when you have a really interesting technology solution, and even when a ton of people sign up for it, which is what's happened to us, which is amazing. There's a whole nother world of how do you get it deployed. And getting it deployed inside this system is complex. It's not just about how do we get our hands on the data, it's also how do we train and handle change management for a very large group of physicians who all are used to doing things the way they want to do things. It's a super complex system, but so was every other industry that has absorbed huge amounts of change, right? The record industry was complex, and the video industry was complex, and making movies was complex. I mean, these are all complex industries. No one can hide from change except maybe the government, right? And I don't mean that like meanly, but they actually can hide from change because they don't have to be an economically rational player. But everybody else in private industry has to be economically rational. It's an economically rational system. So when there's a better mousetrap, when something is truly better, it does get adopted. it may be slower in healthcare than it is in other industries, but it will get adopted. So you're seeing today there's been a mass effort across major academic institutions to begin sequencing patients, to begin collecting molecular data, right? 5, 6, 7, 8 years ago, that wasn't happening. And 5, 6, 7 years from now, it'll be 10 times the size it is now, right? It'll be even more pervasive. Our role, I think, in this process is we understand how to aggregate messy data. We understand how to make sense of it, how to write really elegant software that if we put it in the hands of physicians and researchers, they're gonna get a lot of benefit from it. And if we do that, then even though adoption may take longer than I'd like, it will eventually happen, right? Because 5 people use it, and then 5 other people use it, and then pretty soon everyone's using it, and then they go to some other hospital, and they're like, I can't function because when I was over there, they had better technology, and you got to bring these guys in, and it kind of propagates.
One of the things that entrepreneurs here run into all the time is trying to change the workflow of healthcare can be very challenging.
Yeah.
And trying to change the way that doctors practice medicine, the way that processes are within institutions. And it sounds like, and it's not unique to healthcare, but it's a challenge in healthcare. And it sounds like so version 1 or your beta is you're giving them, sounds like a better version of a report they would get from pathology anyway.
So in every industry we've ever been in, our philosophy is the technology should adapt to the existing workflow of the people in that industry, not vice versa. Asking people to change the way they do something is very complex. And in today's day and age, you can modify technology around somebody's existing workflow. So we don't go to doctors and say, you were doing it this way, you got to do it some totally different way. We go to doctors and say, tell me how you're doing it today, and we'll make sure we support that with much more information that you can digest in an easier way.